And then I think while you're here, we should talk more about what your expectations are and what we think we can tell you about what is going on with your lungs and your breathing, and see if we can take a little bit of that anxiety away.
Right.
Okay. And while we're also trying to see how you respond to the morphine with your breathing, I think we should also see about how we can maybe help with the anxiety part of this, because there may be additional things we can do that would also help your breathing that may not require more of the morphine or a similar medication.
Right.
Such
I've
as
got
that.
pain that comes across here, and I'm afraid it's going to get worse. And when I take a deep breath, the pain gets worse.
Okay.
And so I'm afraid of that too.
Okay. So I think that that is another important thing that we need to sort of investigate today so that we can see how you're responding to the medications, because our goal is for you to not be in pain. And when people are comfortable, sometimes not only does it help how they're feeling day to day and how they're experiencing their life, but actually sometimes it can help us have more time because your body's not focusing all that energy and your mind's not focusing all its energy on just trying to deal with the pain.
Oh, it made me feel so much better.
Yeah.
So, yeah.
That's what we're here for.
Yeah.
That's our goal.
Right.
Okay.
So could I try a little morphine now? And then I know
Absolutely.
nurses watching me,
We'll
and
try
I know the
it.
nurse will come back in.
The nurse will come back in, and I will come back in,
Okay.
and we'll see how you're feeling and how you're responding.
Okay, great.
Okay.
Thank you so much.
And we'll do
Thank
this
you so
together.
much. Thank you.
Okay.
Thank you.
Absolutely.
So we could probably spend a long time talking about that vignette because it's just, you know, so many good things that we saw. We could, you know, spend time talking about what phrases or words the clinician used, about how we could think of this patient using that biopsychosocial model, what was happening physically, but what was also happening emotionally because of her disease and pain, how the clinician addressed her emotions and what impact that seemed to have on the patient. And is there anything else the clinician could have said or done differently? And so in our discussion, we may raise a few of those issues. These vignettes are part of our communication training. We've developed a whole series of videotaped interactions with patients and families to use in our teaching about communication across each of the different domains. So to summarize, I think the key message is that physical comfort is an essential component of compassionate care, that we know that we must prioritize pain and symptoms if we are really to help patients with quality of life, and that good pain and symptom management promotes psychological, social, and spiritual quality of life. And very importantly, that clear, ongoing, and empathic communication is very essential to skilled oncology care. I have a couple slides I'll just jump through, and then we'll go to our panel and discussion. Just as a reminder, this is our LNEC, our End of Life Nursing Education Training Program. On our LNEC website, we have all of this information, our training for nursing schools, for undergraduate and graduate programs, all of our online training programs for nurses across these different settings that you see here. And all of that additional information can be found on our LNIC website. So I'll pause now and turn it back over to our moderators. And we will hear from our other panelists about their thoughts about good communication skills as being an important part of pain management.
Okay, maybe we'll introduce our reactor for today.
Yeah, thank you. Thank you very much, Dr. Farrell. This was a very thorough talk. I almost got really relaxed with the videos that you sent. But before we continue with a question and answer, let me introduce our reactor for today. Okay. Our reactor graduated medicine from the University of Newcastle in United Kingdom and trained and worked in family medicine in the UK prior to returning to Malaysia in 1997. For about 26 years, he has held the position as Chief Executive Officer of Hospice Malaysia, and clinically, he leads the largest community of palliative care services in Malaysia. He is active in palliative care education nationally and internationally, and has been a board member of several national healthcare-based organizations. He is currently the chair of the Asia Pacific Hospice Palliative Care Network and a member of the board of trustees for the Worldwide Hospice Palliative Care Alliance. So to share his insights with us during the Q&A portion, as a reactor for today's webinar, it is my pleasure to introduce to you, ladies and gentlemen, Dr. Ednien Hamza.
Thank you, Betty. Thank you, Dr. Ednien, for participating in this webinar. Pain has always been challenging and difficult to assess sometimes. There are many variables that we see in this part of the world where we're predominantly Catholic and Asian, and we've been raised to endure pain, not to express pain. You know, expressing pain is a sign of weakness, and sometimes you really have to look for it. It's like this elephant in the room, but if you don't look for it, you cannot see. Ednien, in Malaysia, you're dealing with different cultural background, Malay, Indian, Chinese. Do you see any difference in terms of how they express, how they tell you, or how do you tease out pain from this patient?
I think generally they're my experience of seeing patients both in Malaysia and in Asia has been, there's lots of similarities. And a lot of it is really in looking at pain as experienced by not just the patient, but the family as well. I certainly agree with you, Henry, that many patients may not dare even to express that they have pain because they may be fearful of the management and treatment will create further burdens for the family, and they don't want to cause trouble to the family. The aspects of enduring pain potentially as a test of faith becomes a challenge, that they feel like they have to endure this because things like opioids will make them more sedated and they may not be able to communicate. So they feel that enduring the pain is a strength rather than as a weakness. I really enjoyed, Betty, how you address the whole complexities of biopsychosocial elements and looking at getting the patient's narrative as a way of getting very key personal aspects of pain that you would struggle with if you're just asking close-ended questions. Getting the patient to tell us about themselves, tell us about the pain in their own narrative, I think is a wonderful skill that I think all healthcare professionals should have. The other aspect where you said that pain is a symptom of an underlying cause, and pausing, not just jumping to the medication, I think it's so important for people not to think of linking pain directly with medicine. The other aspect that I think we have challenges, Henry, is that many patients may see different healthcare professionals, and it might be that we want to say, okay, you have pain, opioids should be an answer to this, but you then have another healthcare professional that says, oh, morphine is not good, because we have significant gaps in health literacy, even amongst health professionals. So the patient then becomes confused as to why is one doctor saying morphine is okay, and why is another physician saying morphine is not okay. So that's really a significant challenge that maybe we could have a discussion, because it confuses the patient and family. I'll stop there.
Yeah, unfortunately, I've been practicing here in this country for the last 25 years, and we still have this what you call opiophobia. There's an exaggerated fear of using opioids, particularly morphine, and especially now in the United States, Betty, you have the opioid crisis where they, see it in the newspaper, TV, that people are actually dying, and one pharmaceutical being sued by the U.S. government. I think they were forcibly closed or went to bankruptcy, and because of that, we do have an opioid crisis here in this country, and it's the opposite. We don't have the medicines that you mentioned earlier, nothing at all. We are back to morphine, and it's very challenging even to look for this. So that's the dilemma we have. I like to ask about your opinion about that, and also to Edwin if he experienced the same thing that we're experiencing in Manila, where patients with cancer are really having hard time looking for opioids.
Henry, I think that certainly in Malaysia, the access to oral morphine is reasonably good. I think that the challenge is for patients who may not be able to swallow injectable opioids are much more can be quite difficult to obtain. So when patients with head and neck cancers who have intestinal obstruction or other reasons for which parenteral opioids may be needed, that injectable medication can be challenging to obtain. I mean, there is of course fentanyl, but sometimes you may need injectable medication for as required, and we don't have rapid onset fentanyl citrate and things like that.
I guess in the past few years we've been spoiled. We have fentanyl, and we had oxycodone, and we have hydrocodone, but now it's just suddenly it's gone. So we're back to the basic morphine, which is not as bad. Yes.
Yeah, I do despair, Henry, that the situation in America has been overemphasized too much in this part of the world, where we really don't even have access. So when you have all of these scary stories, as you must control all these narcotics and opioids, then it makes it so much harder to get physicians to feel safe about prescribing all the opioids, and that we just have a population that have poor access to essential medicine and opioids. And that becomes very hard when you have a patient in pain and you can do all the assessment, but what do you then do in giving the medicine to relieve the pain?
Right. Do you need a special prescription to prescribe opioids in Malaysia?
You don't.
You don't. So you see that here in the Philippines, we have to get the special prescriptions. You have to buy at the limited prescription pads. So you have to go directly to the few designated hospitals in Metro Manila to get this special prescription pad. So not only that's a barriers, the barriers also looking for the right opioids that we only have very limited. So now I have patients that goes around looking for opioids. And we're talking about, my practice is is in Metro Manila. Can you imagine if you're like somewhere in the islands in this country, it's almost like impossible to have access to opioids.
How about in North America? How about in North America? Does this affect the opioid crisis affect how the patient reports their pain and how much they're taking?
Absolutely. I think it affects every patient, because every person, has heard stories. Every person is seen in the news. Every person, knows someone whose grandson died of an overdose, or who, the horror stories. And so, I started my career in 1977, and when there was very little pain medication, and where we didn't talk about pain, we didn't ask about pain. And it felt like, it took the first decade of my career for us to really advocate for pain management, make medicines available, help people understand how the devastating impact of pain on people's lives. And so there was real progress. And so in many ways, the whole opioid, abuse crisis feels like we've thrown back, 30 years of time. It's very unfortunate, very, very unfortunate. And, yes, it makes our work more difficult, but it's the patients and families who really suffer. So, I hope in time that, we can get back to, the pendulum swing to where we can get back to a much more reasonable system of having medications accessible for patients who really need them. But it's just really very, very difficult.
Betty, the opioid crisis in America, is it prescription from the doctors, or is it illicit prescriptions, or they buy it in the street, or is it, I like to clarify because
Yeah, I mean, it's
we-
it's very complicated, and there have been, many, I mean, hundreds and hundreds of national reports and lots of data, and it's very complicated about, certainly there was, some abuse that was created by physicians, clinicians who were inappropriately prescribing or prescribing very high doses of opioids for long term for patients that had mild pain problems or no pain problems, or short-term pain problems. So there are lots of causes. There also is really the drug cartel, that had nothing to do with clinicians or hospitals or people with cancer, but just the illicit sale of medications. But regardless of the cause, it's patients who are paying the price. And there's, now clinicians are concerned about their own liability, and so many clinicians have just said, we're just not going to prescribe. If the patient really needs these medicines, they're going to have to go see a pain specialist, but as a primary care doctor, we're not going to prescribe. So we have a lot, it's going to take a long time to sort out the harm that's been done, for sure.
And most of these deaths related to opioids are purely from opioids alone, or were they in combination with other medicine that the person is taking?
I think most of the reports, have really documented just the sale, street, just very illicit sale of opioids that were, obtained through various, very illegal ways, and then sold on the street. And a lot of opioids and, were diverted. And it's quite complex, and it's hit rural communities and poor communities, particularly hard. There are, states that, the devastation to their own economies, to, the people in their state, the amount of money that it's, costs the healthcare system to deal with. All of that is very, very real. But I think, again, to go back to, and knowing that all of those things are happening tells us how much harder we have to work to make sure that we do a good assessment and that we help people get the pain management that they need, because it's harder now than it was when I started. And so we still have to be the patient's advocate.
Clearly a challenge, right?
Yeah.
So can you give tips, like from Dr. Farrell and Dr. Hamza, on probing about these difficult questions? For example, the patient cannot really deliver information because they're trying to hide where they got some medications, for example. How do you try to probe in a very prudent way? Can you give us the tips for our participants on how you go about telling them or getting their trust so they can tell you?
Dr. Hamza, do you want to start?
I would go with your first question, Betty. It's asking them what they do in their lives and what they can't do. It's becoming a detective. What function that they used to enjoy that they may not be able to do anymore. They may not be able to walk as much as they used to in the garden because they've got pain in their legs. So you look into potential deficits in patterns, and probe and thinking, why is that happening? And sometimes the word pain doesn't come out. So they may say that I can't really move my leg. I can't walk. And then you have to be looking at, okay, if they don't want to say pain, then you might want to do it as a clinical examination. And then they say, ouch, it says that hurts. So you go around a little bit and find a way through. I think one of the challenge is when the patient has pain, and that is not, the family says, don't believe that person. He or she is just attention seeking. And their narrative is denied. I mean, their story is denied by the family. And that requires really careful negotiation, I feel. Potentially, isolating the patient from the family and asking for, oh, can we have some privacy? I want to examine the patient. And maybe at that time, creating a net of safety where you can really get a sense of what's happening there. But that's a bit challenging at times.
Absolutely. And I think that's why, we've always known that pain management is a very interdisciplinary, discipline, because we need our social worker and our psychologist and our chaplains, and we need everyone to be committed to pain management, because often there are, long-standing family dynamics and all kinds of factors. And it's hard to really, keep focused on the patient and the underlying cause when there's lots of social and family dynamics involved.
That makes a huge difference, because dealing with that can lower or raise the pain threshold, and it makes the analgesic elements work better. If we reduce the
And one of the challenges also is like neuropathic pain. It's difficult to express, describe the sensation that the patient's feeling. So you could be having experienced neuropathic pain, and there's a difficulty. It's described as a poor verbal descriptors. And how do you say that, in your language? We know about tingling sensation, we know about, paresthesia and dysesthesia, but how do you translate that in Bahasa or in my language, in Cebuano? It's going to be difficult, with these descriptions. You have problems, you have experienced that, Dr. Edin?
I think it's
that maybe you're dealing with neuropathic pain, and the patients just have a hard time, describing it.
Well, they will use all kinds of terms, and then you just need to figure out what those terms mean. I think sometimes you need to ditch English and then deal just with the local language, because there are different words that have no meaning in English, and vice versa. Some of the English terms don't really have a similar meaning in the local language. But some of the sense of what you might get into burning and shooting, you can get that through a descriptive sort of communication aspect from patients, and you just need to figure out what does that mean in terms of what we know, into the way that we describe the sensations in English. You build up your own vocabulary.
Yeah, we try to translate the pain detect, to Filipino language.
We have some in Malay.
It's validated.
Translated into English. I have no idea what it would translate, but I recognize it is a term that is associated with neuropathic pain.
Yeah, and the words in Tagalog, I cannot even understand. So, even for me, I have difficulty what the term is all about. How much more if we have like hundreds of dialects in this country. So we have 7,000 islands. So it's going to be challenging to even translate that in different dialects. Sometimes they believe that pain is like, curse. Someone is doing them about a voodoo, So that's in some islands, they believe that, they'll be cursed by someone, and they totally believe that. And so it's a challenge in terms of how to tease out this experience from the patients.
Maybe we can wrap up with one question, last question from the attendees. They say, hearing the different situations in Asia and America regarding the availability/unavailability of opioids, may I ask, how can we address the issue of reaching the uninsured or underinsured? I think it's more like asking, how do we become stewards of for these patients, and noting that these patients have high anxiety, whether they are available or unavailable, and the stigma that comes with it. Maybe hear from Dr. Hamza, and then lastly from Dr. Farrell.
I think this is a common problem everywhere, especially in low resource countries. You have got many regulations around essential medicines and opioids that restrict access. But I think you need to come up with some data. You need to be able to show the prevalence of pain. You should need to be able to show that pain can reduce, opioids can reduce pain. And that's where I think that certainly, Henry, many of the countries in Southeast Asia have adopted pain as a fifth vital sign, and having pain-free hospitals. So these are some certain things that maybe speak well to policymakers, and more of this and more campaigns and showing the impact of pain on lives and how essential opioids can help with this. And the studies in other countries that have shown significant difference. It's talking to the right people in government. These are policy issues. And if you can get to the right ear, with the right level of authority, and hopefully you can get this solved.
Okay. Thank
Not
you,
a-
Dr. Farrell.
Yeah, I would definitely echo, that we need to think of pain management as a public health crisis. And that if we want to speak to policymakers, whether we want to impact access to medication or payment for medication, we need data. And so collecting information about, what is the prevalence of pain and what are the sources of the pain and what happens to people because of their pain. How many people are hospitalized? What is it costing our healthcare system to care for people who have unrelieved pain? Having good data and really addressing at a public policy level is really important. And, as clinicians, we should be storytellers, right? We see people, we see the impact on their lives. And so we have the ability to tell the story and to put that human face on this problem of pain. If policymakers, the moment they hear pain, they immediately think of substance abusers, that's not good. We need to tell them about the grandmother that can't take care of her grandchildren, and the person who can't go to work and support their family. And so I think both sharing the human element, but also having good data and good outcome data. What happens when people do get good medicines or are seen by pain specialists? How, what's our outcome data that shows that this is a good thing? But unrelieved pain is a major public health concern, and we all need to continue to echo that message.
Okay. Thank you, Dr. Hansen. Thank you, Dr. Farrell. Anything else, Dr. Lim?
I'm okay. I was about to ask you about, the world has changed a lot. Nowadays, there are several countries that now legalize the use of marijuana, not only for medical use, but for recreational use. In Thailand, they allow it for recreational use. Here is you can be in prison for life if you use marijuana. And is there any impact in the use, in the management of pain in the presence of marijuana in the United States legally?
Yeah, and it's been a very complex, again, an issue that's been going on for years, and many states now have legalized access to marijuana, both for medical reasons, but also recreationally. There's abundant data. There's abundant data and abundant reports, and so just Google and you will find abundant, well-written reports that summarize what are the findings. That most of those will say that the outcome is that that marijuana just for most people does not have an analgesic effect, is not a really good pain reliever. There are there's data about perhaps for some patients the impact of or the use of marijuana for decreasing their other symptoms. But there is a lot of data, and again, this is these are complex questions, and it's always a matter of weighing, the benefits and the harms of any medication, and then granting access. What does that do in terms of public access, and how does that add to our real health crisis related to substance abuse? But there's a lot of data, and a lot of countries now, have a lot of data about what's happened with legalized use of, various controlled substances.
I think that was
Do you have any experience with the use of marijuana in Malaysia before we call it a day?
Don't like it. I've told people it's not available and it's not legal. And when people ask me, I would say we've got many other essential medicines that we don't have. Talk to me about those, make those available before we talk about marijuana. So I just tell them there are other things that are more important than that.
So with that, I'd like to thank Dr. Edwin for your time and your expertise, and of course our dear friend Dr. Betty Ferrer for finally agreeing to be our speaker for today. I would really like to invite you again here in Manila, and we'll have another rounds of Filipino buffet in the future. Hopefully
Thank
in
you.
the future. So thank you.
Thank
Very
you.
nice to be with all of you. Thank you so much. And thanks for your leadership. You're doing great work in your corner of the world that's impacting so many people. We watch what you're doing, and we really admire very much your commitment to patients, but also modeling what good pain management looks like. So thank you so much. It's nice to be with all of you tonight.
Mhm. Thank you.
Good night. Good
Thank
morning,
you.
everyone.
Thanks. Bye-bye.
Yes. Thank you. Will allow me to present the certificate to our guest speaker and our reactor before we close the session. This certificate is reads the Global Pain Specialists and Associates present this certificate of appreciation to Dr. Betty Farrell for her invaluable contribution as speaker during the 18th virtual seminar series on pain and palliative care entitled Communication Skills for Assessment of Pain and Symptoms, given this 26th day of October 2023 in Manila, Philippines, signed by our heads in our group, Dr. Jocelyn Ke, Dr. Lourdes Cabaluna, and Dr. Henry Liu. And likewise, we're presenting the certificate of appreciation for Dr. Ednin Hamza for his invaluable contribution as reactor during this webinar. Thank you very much, Dr. Farrell and Dr. Hamza. Can we take a last photo moment? Because this has been very fruitful, a session on the communication and skills and assessments webinar. All right. Thank you. Someone taking it. All right. I think probably that was already taken. Thank you again. And hope to see you in.
Thank you.
Thank you. Thank you, everyone. Bye.
Person.
Bye, everyone.
Next year.
Thank you.
We'll have webinar next year. Thank you.
Can we show the evaluation form slide, please? Dr. Liu, how do you think the session went?
Yes. Are we still open to the
Yeah,
public?
we're still on because
Sorry.
the participants are encouraged to scan the QR code. The link will be sent in the chat box for our participants to answer the evaluation form so that they can receive their certificates of attendance.
All right. See you next year.
I'll sign off now. Goodbye, everyone.
Thank you, Dr. Farrell.
Good night. Good night, Betty. Good night.
Good night. Great to see you, Henry.
Okay.
Bye-bye.
Same here.
So for our participants, we also have like a video from our industry partner Medicam. If you can stand by for a bit so that we can give them a time for this session. We'll be posting the link for the evaluation.
Chronic pain impairs our physical function, prevents us from moving towards our goals, and limits us from having the quality of life we deserve. So, with a commitment to enable people in need, Medicam, the CNS subsidiary of Unilab, aims to help patients with neuropathic pain. Help them function well with pregabalin function. Pregabalin has been rated as the only level A treatment for patients with diabetic peripheral neuropathy.